guys, we have the topic of Down syndrome. Okay, so Down syndrome is a genetic disorder caused when abnormal cell division results in extra genetic material from chromosome 21. The chances of Down syndrome increases with maternal age, and this is because older eggs have an increased chance of improper cell division. Also, if a mom already has a child with Down syndrome, there's an increased chance of having another child with Down syndrome. The prevalence of Down syndrome occurs 1 in 700 live births. Okay, so those with Down syndrome have low muscle tone, and the muscles in their mouth and tongue may be weaker. There's also some debate on whether or not children with Down syndrome have an oversized tongue. Some might say that they have a larger tongue, while others might say this is actually a result of the low muscle tone. They also have distinctive facial features. Their eyes might slant upwards and are almond-shaped. The ears in individuals with Down syndrome can be smaller and are slightly placed lower on the head. Some individuals with Down syndrome have a thicker neck. There are some other physical traits of Down syndrome listed on the slide. However, not all individuals with Down syndrome will exhibit all of these characteristics.
Okay, so individuals with Down syndrome also have an increased risk of health concerns, mostly related to speech. The ones that we're concerned about the most as speech language pathologists would be hearing impairments and also recurrent ear infections. But some of the other ones include visual impairments, congenital heart defects, obesity, and it also increases their risk of dual diagnosis due to their intellectual disabilities. So also going along with that, about 10% of kids with Down syndrome are also diagnosed with autism at the same time, which could increase our need for therapy as SLPs as well to help them with pragmatic difficulties that come from the autism diagnosis. Then later in life, people with Down syndrome are also more prone to Alzheimer's disease, which can also increase our need for services later in their life for speech and language. So some of the cognitive characteristics of Down syndrome include mild to moderate intellectual disability. So this is what mostly impacts speech and language development the most. The developmental delays are in fine and gross motor skills as well, which can also then go along with the delayed speech and language. So this impacts speech and language development and processing. So they have a slower processing speed when it comes to language and cognition. This also affects executive functioning, which we'll get more into later on with our therapy approach. And then they also have difficulty learning and applying new rules. So this could be really challenging for them once they arrive at school age.
Okay, so now moving into the language characteristics of Down syndrome. And before I get into form, content, and use, I just want to say that receptive language is typically stronger than their expressive language. And these language characteristics may vary depending on the severity level of the individual. So first, starting off with form, typically for an individual with Down syndrome, their speech intelligibility is poor and usually have atypical speech sound patterns. The individual may have abnormal articulatory structures that may be responsible for mispronunciation of sounds. Relating specifically to morphology, they typically have a limitation of tense markings. For example, they might not use the ed ending when talking in past tense. Relating to syntax, individuals with Down syndrome tend to use shorter and less complex sentences, and their sentences usually have grammatical errors. Their syntactic ability may decline in their later adulthood. Okay, and now going into semantics, so their vocabulary. Their vocabulary is a stronger aspect of language than their syntax. The acquisition of first words is usually delayed in children with Down syndrome, and their growth of expressive vocab is slower than expected. Okay, and now going into their pragmatic, so their social aspects of language. This is actually considered an area of strength, and individuals with Down syndrome are able to use a variety of communicative functions such as commenting, answering, and protesting. They also have pretty good conversation skills and are able to maintain a topic in conversation. Okay, so now moving into literacy. Typically, individuals with Down syndrome tend to resemble the profile of poor comprehenders. They also score similarly on measures of print, letter sound, and letter identification compared to typically developing peers. And when given a word identification task, this has been identified as a strength for individuals with Down syndrome.
Okay, so some of the symptoms of Down syndrome that are related to feeding and swallowing, like Jordan said earlier, they have hypotonia, so this affects their muscular strength, which also relates to them having low oral muscle tone. So this is all having weak muscles in the mouth, including their lips, cheeks, and tongue, which can affect speech. This results in weak lip closure, so this could also affect the swallowing and feeding aspect, as well as aspiration. So one of the common things that is targeted during early intervention with kids with Down syndrome is breastfeeding. So this can help to target and build oral muscle strength that's going to be needed later on when developing speech. And then kids with Down syndrome also have a strong tongue thrust and poor chewing. This is also going back to the low muscle tone. So the focus of therapy for kids with Down syndrome, ultimately the goal of therapy is going to be to improve their receptive and expressive speech, language, in academic, social, and vocational areas. And as always with any kid, the goals of therapy are going to be made in collaboration with the family and the client. This helps to make the therapy individualized for the client's needs, since Down syndrome can have such a wide range of effects and symptoms. Therapy targets will be based on their unique needs. Treatment targets will change throughout the course of the lifespan to account for functional skills in the individual's life at the time. So, for example, in early intervention, a goal would be to develop the speech muscles, like we talked about with the goal of breastfeeding. As in later in adulthood, goals for therapy with a person with Down syndrome could be targeting the pragmatic and vocational skills that would be needed to acquire a job or in a career. So some of the possible intervention approaches that we can use as SLPs to target all of the goals that may be needed for a child with Down syndrome. The first one would be enhanced milieu teaching. This can work for all aspects of language that we would be targeting, but for phoneme production, we could target the early vocalizations and speech sound targets through lots of modeling. We could target pragmatics through modeling gestures and focusing on eye gaze and joint attention to initiate conversation exchange skills that they'll need for later. Syntax can be targeted through lots of modeling of language structure and sentence structure. Semantics can be targeted through lots of vocabulary exposure, lots of reading books and exposing them to new vocabulary. And then literacy can be targeted through targeting those early developing literacy skills, so lots of modeling and labeling while book reading, along with the dialogic reading approach that we used. And then social stories can help kids with Down syndrome to target pragmatics. So this can be recognizing and signaling when they have not understood something. A lot of kids with Down syndrome have difficulty finding and recognizing the important aspects of things like signaling when they have not understood something. So social stories can help them to recognize those signs. And also executive functioning and impulse control, which we'll get to later when we talk about our therapy approach. Visual strategies can be used when helping them to attend to relevant information. So like I said, they have difficulty sometimes picking out the important pieces of information that they need. So visual strategies can help them for that, and also for staying on task. So this can help them just for daily tasks like getting ready in the morning or at school for doing academic tasks. And then AAC devices can be used with children with Down syndrome who have less verbal skills and this can also be due to the oral muscle weakness. But things like PECs and iPads and apps like that can be used to help kids that don't have the verbal language skills. And then sign language can also be used in early expressive and receptive language, and if this proves to be functional for the child, then it can also be used later in life as well. So some of the expected communication outcomes for children with Down syndrome. So since Down syndrome has such a wide range of outcomes that depend on the severity of communication disorders and the intellectual ability of a child, as well as their potential medical problems and other complications, early intervention, we often see this is where we target the building of speech muscles and pre-linguistic skills. Early intervention has always been proven to improve the communication outcomes for children with Down syndrome, and most parents do choose to have these services implemented with their child. School age interventions often are accompanied through an IEP, which is also through IDEA. So children with Down syndrome, since they fall within the population that can be covered by IDEA, they can receive school services through the age of 21. And the IEPs also are implemented with the family and client in mind, and the therapies and the treatment targets that they're looking to receive through the IEP. And then in the adult life, so we talked about how people with Down syndrome have a higher prevalence of Alzheimer's later in life, so this could also affect how and when they will need therapy from speech-language pathologists in their adult life. But most adults do choose to have elective services that continue beyond the age of 21, but that, like I said, this depends on the individual's severity, strength, and individual needs. And then these are some of the family resources that we found. So these are family supports, community involvements that families can get involved in, research and case study results, new news about Down syndrome findings, and lots of events that are going on and families can get involved in. And then these are our references for the project, and then we're going to be getting into a specific therapy approach that we can use for children with Down syndrome.
My name is Jordan, and I'm a student clinician at the University of Toledo, and I am about to walk into an elementary school classroom because a teacher has concerns about an individual with Down syndrome and his lack of impulse control by not raising his hand when he has a question to ask. We as speech-language pathologists know that a lack of executive function is common with individuals that have Down syndrome. I am here in the teacher's classroom, and I have brought in a social story. A social story is a therapy approach used to target pragmatic skills. In this case, we are targeting the executive function of impulse control of having the child raise their hand whenever they have a question. The story is always read from the child's perspective and used to specifically target the skills the child is working on. Now I am going to give the teacher a model of what reading the social story will look like. I am here with the student Jane, and we are going to be reading a social story about how to raise your hand in the classroom. When I do my work, I like it when it is nice and quiet. I can concentrate better when it is not noisy. Sometimes when I am working, I have a question. If I yell out to my teacher, this can make my friends angry. If I raise my hand, I do not disturb my friends. Let's raise our hand. If I raise my hand, my teacher will see that I have a question. My teacher will come and help me when she sees me raise my hand. I will be happy that my teacher helped me. My friends will be happy that I did not yell to ask for help. I will raise my hand when I have a question.
Thanks for watching our presentation.